Hello everybody, welcome to my first blog. My name's Nicola Senior, I'm the lead for Health and Justice at North of England Commissioning Support. We work with NHS England, helping them to deliver their commissioning intentions around health and justice, looking after the offender healthcare population in prisons and secure settings, children and young people and adults. So I'm here reporting live from Spain, and I'm actually taking part in the HOPE Exchange, which is a European funded programme which helps to share best practice internationally around different healthcare issues. And I'm here to explore offender healthcare because that's my area of speciality. And my focus around my mission for the next month is to explore how the patient voice is a part of practice within offender healthcare and the offender healthcare system in Spain. So my programme has been put together by lots of different people and supported by lots of different people. So I've sought some advice from WEFREN, who are the worldwide prison health research and engagement network, who've advised me to visit certain colleagues in offender health over in Spain. Some colleagues at NHS England have also advised me of some areas of good practice in Spain, particularly around children and young people. And also I have an official programme from the HOPE Exchange where they have set me up with particularly high-performing hospitals over here that have good links with offender healthcare as well. So I'm particularly interested while I'm here in looking at some benchmarking, some research that was done by Mark Britnell, which talks about the 5 principles behind the world's most efficient healthcare services. So I've always got these at the back of my mind as I'm visiting all the different places. And he talks about 5 key principles that must be present for a positive healthcare experience in a country. Integrated care, hospitals as health systems, standardise and simplify, take social care seriously and pay a power. So I'm going to have those at the back of my mind as I'm talking. So what I'm going to cover today on the blog is around 2 key areas that I have worked on so far and the places that I've visited this week. I'm going to look at the experience I've had with regards to adults in the criminal justice system here in Spain and also children and young people in secure settings. So I'm going to look at what have I seen, what's the same, what's different, and how does the patient voice interact with the system. So let's start with adults in the criminal justice system. So what have I seen and who have I visited? So I've met with the Ministerio de Justicia, which are the equivalent of our HMPPS Ministry of Justice. And I met with José Manuel Arroyo Cobo, who is the Deputy Director General of Offender Healthcare based in Madrid.
Good morning. I José Manuel Arroyo. I am José Manuel Arroyo. I work in the Spanish prison system as a head of prison healthcare.
And one of his colleagues who works in an early pilot liaison and diversion project in the north of Spain. So what's the same in offender healthcare over here? There seems to be a similar complexity of social issues, health issues and offending behaviour that we have at home. Their focus is pathway development, particularly into secondary care settings and community settings. There seems to be a lack of early intervention, particularly around mental health issues. Dual diagnosis and also waiting times between prisons and secure mental health settings are also a challenge. So what's different? A lot is different. The situation is completely different to how we have at home with regards to offender healthcare. Each individual autonomous community in Spain has responsibility for offender healthcare. So there's a central Ministry of Justice, but there's very little kind of central direction of travel and commissioning intentions and strategy and coordination. So actually each individual area looks completely different with regards to how they deliver services for offenders. So each individual area can choose their own budget, their own system, their own way of delivering services. So the differences between regions are massive, whereas in the UK, equity of service and service delivery is fairly similar across the board. So what is the role of the patient voice in Spanish adult offender healthcare systems? What they talked about was a written contract between patients within a prison setting and clinicians, and a patient actually has to agree to information sharing and to work together in a collaboration, which I thought was really interesting, and that the clinician would walk through that with the patient, something that we don't necessarily do here in the UK. There's a pilot project that I learnt about which sounded absolutely fantastic, which is the kind of Spanish version of liaison and diversion taking part in the north of the country, which puts the patient at the heart of service delivery and healthcare delivery. So it's a multi-agency meeting where patients are referred onto particular pathways outside of the criminal justice setting, and they've had amazing outcomes. And this really does put the patient voice, and the family of the patient, who are a key part of the process, into the centre of everything they do. And the outcomes have been absolutely 80% of people on the programme reducing their offending and their risk of going into a prison setting. And the buy-in has been amazing from the integrated multi-agencies involved in that process. This is a really small project, and they're looking to roll this out nationally, but again, very much dependent on funding. And I know that the Spanish that I met with were really interested in hearing about the liaison and diversion work that we do in the UK. So one thing that seems to be really positive is that the patient experience seems to be very positive, because the services seem to be fully integrated, particularly including social care. So there seems to be one pot of money that comes from the autonomous community that funds all services within a prison setting. So it funds the cleaning, the food, the social care, the healthcare, the education, which means that the service user is at the heart of everything, and there doesn't seem to be lots of different contracts in the way that we work here. So actually, the impression that I got was that the patient experience and the patient voice is really at the centre of everything and all the services that are delivered. So really interesting, lots of interesting observations around some of the key differences. The children and young people here in Spain is very similar, incredibly complex. There's also a high prevalence rate of substance misuse, mental health, interfamily violence, low levels of education. So a lot of the same barriers that we face over in the UK around a very complex cohort of children and young people. But what's different? This is one of the biggest differences that I've seen. I thought that the adult offender healthcare system was different, but nothing's really prepared me for what I've seen from a children and young person's perspective. And coming from a CYP background myself, a youth offending service background, this was incredibly fascinating to me. So what's different? So we're almost seeing a case of mini accountable care systems in each secure establishment. So you've got one integrated pot of funds with all the service providers collaborating and being held account by each other, to each other. They all have the same objectives, and the service user really is at the heart of everything that takes place. Another really interesting difference was that the pathways are really well developed with community services in the secure settings for children and young people. So an example of that is that a young person may use ROTL, release on temporary licence, to go to school every day and come back in the evening, or go to leisure activities, or also go into healthcare facilities in the local community. And because the prisons are in the local community, it means that they will continue to use those services in the future. So there's real continuity of care for patients. They will be using those services before they come into prison. They'll continue using those healthcare services whilst they're in prison, and then they'll use them again on release. So instead of our young people, who are often sent hundreds of miles away to different sets of doctors, nurses, clinicians, schools, different schools, they will continue, they'll remain in their community, continue using community services, and that will provide improved outcomes for the patient. Another massive difference was around the staff that interact with the children and young people. So we talked about them being at the heart of everything that takes place on site. All of the staff interacting with that child or young person, and this was the same in all of the places that I visited, are all highly skilled, highly trained professionals. So we're talking that around the children liaising with either social workers, teachers, psychologists, psychiatrists, clinicians. There is very limited interaction with people who don't come from a child-centred viewpoint. So there's very minimal interaction with security. That's almost, it's there, it's in the background, but it's very hidden. So it feels very like a real therapeutic environment. And as a result, the healthcare outcomes are much improved than we have here in the UK. There seems to be a holistic approach to health. This is something I found really interesting. So, for example, in the UK, we may spend a lot of money on service specification, delivery and implementation of healthcare approach, but actually here they look at things healthcare holistically for the children and young people. So there seemed to be a massive focus on good food, really good infrastructure, so lots of light coming in, lots of bright colours, health promotion, leisure activities, art therapy, sport. There was fresh air, there was views outside, beautiful views. There was a lot of personal ownership of people's own bedrooms and people's own action plans and healthcare plans. So a lot of kind of self-care. And all that seemed as important as the medical intervention. And that was something that I think we may be missing a trick on at home, because we may spend a lot of money on the medical intervention, but do we think about things holistically? That's really difficult to do that when we only have a pot of money to spend on this, whereas those other services might be commissioned elsewhere. And that's the challenge for us as commissioners, to be able to think about that and work in that integrated way. So what's the role of the patient voice? So it was interesting. It seemed like the patient voice for children and young people in Spain in secure settings was much more of an active voice. They seemed to play a really active role in their own management of their own conditions and their own decisions that they make in a secure setting. It didn't seem to be that paternal model. That the kind of care and collaboration between the staff and young people was great. And so different. There was a real caring kind of feeling as you were walking around. And for me, that really encourages the patient voice to become active and become part of the system. It felt like it was an empowered voice. Everywhere you went, there was kind of declarations that the children had signed around how they were going to impact on their healthcare, how they were going to impact on their education, and it felt like a very positive environment. And it seemed also that service redesign was constantly being kind of moulded by the patient voice, and that felt really evident as you were walking around. So, conclusions. Going back to those kind of 5 key points of what makes a good healthcare system, I've seen those 5 points in spades in both the adult healthcare system and also the children and young people system. We're looking at integrated, seems to be massively prevalent here. Rather than hospitals as health systems, it seems like the prisons are health systems. It doesn't seem like they're in isolation, which sometimes feels as though they are here in the UK. They feel like they're part of a wider system with lots of integration with community healthcare settings. Standardise and simplify. I think we saw a lot of standardisation, particularly on visiting the diagramma sites, where they had that same model of that active patient taking ownership of their own care. That was evident in lots of different settings, regardless of the service user, whether it was a secure mental health setting or a secure children's home. So again, same model in different locations. It was an integrated model of social care. And again, that characteristic of payer power, one pot of money for adult and children's services. And I've called this blog the Integration Flowers and Turtles, because everywhere I went on my mission over the last week, there's been flowers and there's also been turtles randomly. I don't know why turtles are around, but that seems to be a thing. And it's just really about that holistic viewpoint. So things like infrastructure, flowers, animals, it just really, to me, brings home the holistic approach that there is here around healthcare for offenders, and that we need to think wider than just actually the intervention that's in place. Okay, I'm going to stop talking now. I've got lots planned for next week, so we're going to look in the next blog around a little bit more around the telemedicine. We're going to look at some of the transformation work that's been going on in a hospital in Barcelona. So I'll report back next week with a few more findings. Thanks for listening. Bye. So I'm going to leave you with some photographs from some of the secure settings from Diagramma, just to show you the quality of the infrastructure and the quality of the food, which was fantastic. Thank you. Bye.